good afternoon, everyone. I'm Nikki Bozanov, one of the co-chairs for today's conference, and I have the pleasure today to moderate the panel OAT in the Time of Fentanyl. I want to acknowledge that I'm calling in from the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And I invite everyone who is joining us today to write in the chat who they are if they want, where they're calling from as well. We have an exciting agenda for this afternoon. I want to start by introducing Dr. Louisa Marion-Bellemare. Dr. Louisa Marion-Bellemare graduated from and completed her residency at the Northern Ontario School of Medicine. She works at the Timmins and District Hospital Emergency Department, the Pediatric Mental Health Unit, and in the addiction clinics in communities along the James Bay coast. Dr. Marion-Bellemare can also be found working at the Indigenous Healthcare Center and the local provincial jail. She's the co-lead and works with the addiction medicine program at the hospital, which includes the addiction medicine consult service and the community withdrawal management service. She's actively involved in her community by promoting barrier-free access to addiction treatment with the ultimate goal to save lives and improve quality of life. Also with us today are Dr. Sam Young and Dr. Olivia Brooks. Now I'm going to cede the call to Dr. Marion-Bellemare. Thank you.
Hi, everybody. Thanks so much for attending. I think this will be a really exciting panel. So I'm discussing macrodosing and rapid extended release buprenorphine inductions. This is something that we're doing in our community. Disclosure, I have no financial support from any organization, no in-kind support, and there's no potential for conflicts of interest. This is me doing the talk, no commercial interests. I have no biases. And of course, this content reports on mostly clinical experience, especially during the contaminated toxic drug supply, and as such includes off-label uses. I just wanted to give some context about what sort of fueled myself and my colleague who's usually presents with me, but she's actually in Vancouver at her son's graduation. But we started recognizing as emergency rooms physicians that people were coming into our merge. And for some reason, we thought that the emergency room wasn't a place to treat people who suffered from substance use. And we started recognizing and realizing that it was the leading cause of death for people between the ages of 25 and 45. And we at one point were the worst in the province with respect to overdose deaths, and probably the worst in the country if we really broke down the stats. And so realizing we needed to treat this. It is a medical emergency. Untreated substance use is life-threatening. And every time somebody presents to our merge with a non-fatal overdose, the risk of death increases in days and months and years following that non-fatal overdose. Just like somebody who comes in with a small heart attack or acute coronary syndrome, it increases the risk of having a larger coronary event. And of course, when people are seeking help and they're coming to our hospital and our merge, it's a fleeting moment in time, and it is an emergency because if they leave, their risk of death is very, very high. You've probably had this discussion a little bit today, but I'm just going to put it in context. This is the way that I sort of, when I'm talking to my colleagues, make them understand how powerfully addictive this drug is and how high patients who use opiates, specifically fentanyl, their tolerance to this is. In the emergency room, if someone dislocates their shoulder, who comes in who doesn't use fentanyl, I use about 25 to 50 micrograms of fentanyl along with some other medications to sedate them slightly to reduce their shoulder back in. My patients who are using fentanyl, so imagine I use 20 to 50 mics for someone who doesn't use fentanyl. Someone using fentanyl will use up to 39,000 micrograms a day of fentanyl. So I like to put that into perspective, 25 mics versus 39,000 micrograms of fentanyl. So we need to understand why we need to treat our patients who use substances with higher doses of medication to control their withdrawals and cravings. The American College of Emergency Physicians came out with a consensus report in 2021, and this helped us fuel even more what we wanted to do, changing culture and the dynamics and how we treat people's substance use in our emergency department and in our hospital, specifically in our community of Timmins. And it made us, it gave us a little bit more ammunition to move forward and say, look, we need to change what we're doing. And the recommendation is on the treatment of opiate use disorder in the emerge. The emerge is a place where we should be treating. It's like any other medical emergency. Also, the Canadian Association, so the American Association supports it, and also the Canadian Association of Emergency physicians also put out a position statement stating that the emergency department is a place. And this is where we're pushing forward, saying emergency departments across our country, across our province, have to start adopting this standard of care and recognizing that we do treat people and we should be treating people there. The treat and treat them approach is not effective in the emergency room. We know that less than 20% of people who should be started on OAT or treatment were not, but we do know for those who were started, about 74% of them will remain on treatment 2 months after. This is huge. We know if we offer treatment and we start people on treatment, they can remain. And I always say this to people when people say, well, they never want to stay, our patients never want to stay on treatment. I say, well, if we don't offer them treatment in their time of crisis, they can't stay on treatment. And of course, the Emerge, there is no other setting. We cannot expect community organizations to be open 24 hours a day, 7 days a week, 365 days a year. The Emerge replicates all our access and wraparound services. EDs are the place where people show up at 4 in the morning. Community organizations aren't open at 4 a.m. The ED approves access to OAT for many patients who otherwise not seek help. I have patients who come in with a pneumonia and we find out that they have opiate use disorder. They came for their pneumonia, but we can treat them for their opiate use disorder, give them a chance to start treatment. That patient may not have otherwise sought help in the community. So we're giving people a chance to experience treatment when they present to the Emerge for many other reasons. I like to show this slide a little bit. This is about healthcare service use among people at risk for overdose. And it says that 1 in 2 people had a healthcare encounter in the 30 days prior to their death. What's even more staggering is 1 in 4 had a healthcare encounter in 7 days prior to their overdose death. And of that, 6% of these people were seen in the Emerge. So what we're trying to prove to people is that patients with opiate use disorder are being seen, are coming to our Emerge in our hospital, and we need to treat them. There's also been a shift with respect to primary care. We know that the last 7 years, with respect to fentanyl and the toxic drug supply, that more and more people have opiate use and are using substances. And because of the increase in overdoses, with the growing evidence for the effectiveness of buprenorphine naloxone, it means that addiction treatment cannot be a niche industry operating in the fringes of the healthcare system. As primary care providers, we do not have to have a specialty in addiction treatment. We need to start treating our patients and asking the right questions, even in our offices, even in our clinics. We can't just wait for patients to see a specialist. Buprenorphine naloxone is extremely safe, and it's a first-line treatment that we can provide to allow people to treat their cravings, to treat their withdrawals, protect them from overdose, especially in that time when they're in desperate need. Now, that may not be the treatment that they're maintained on, but at that time when they're asking for help, it's the quickest, easiest, safest medication we can give. When we look at the progress in opiate use disorder treatments, I see it's like any medication, like antihypertensives, for example, medications for diabetes. Over the last 20, 30 years, there's been big changes. Methadone was the best and only medication we had to treat opiate use disorder, 20 or 30 years ago. But over time, like anything, we don't use the same antihypertensives as we did 30 years ago. Some people are still on those medications, but there are new medications that have improved compliance and have improved safety profiles. Although there are many medications that are 30 years old that are still very important to use, but we do have options that have been game changers and life-changing for our patients, including long-acting depot buprenorphine. You guys know this, but the evidence and effectiveness for OAT, I'm going to go through this quickly. It decreases mortality, you know this, and that we know we can have yearly retention treatment rates up to 74%. And people need to be started on treatment to remain on treatment. I love this slide. It really sends home the importance of offering and helping people and get started on treatment. All of us sitting here today there's a general risk of us dying. Just being alive every day, we have a risk of dying. But those who are not on treatment for substance use, specifically opiate use, have about a 6 times greater risk of dying. Interesting, if you look at the blue line, those who are started on OAT, that reduces their risk to almost that of the general population. Whenever I look at a slide, it amazes me, thinking this is why in the emergency room, in our hospitals, we need to treat people. If we can have that profound of effect by treating them with this medication, that their risk of death is almost that of the general population, we need to be doing this. How safe is buprenorphine naloxone? You know, I get sometimes very frustrated having discussions over and over again about the safety of this medication. You know, people call me, people are using fentanyl, which we know is one of the most potent, if not the most potent opiate out there. Plus it's contaminated. Our patients are using off-label use fentanyl every day of their lives. Buprenorphine naloxone is a partial opiate agonist. Fentanyl is a full, very powerful opiate agonist. And people have major upregulation of their opiate receptors and a huge tolerance. Buprenorphine naloxone is a partial opiate agonist. It cannot cause people to stop breathing. And, you know, I hear people say, well, you know, they're on fentanyl, but I just started them on 4 milligrams of Suboxone. They're using the most potent agonist pretty much that exists. And we're giving them a partial agonist and we're worried they're going to stop breathing. They're using a drug on the street every day that can stop them from breathing any minute. Buprenorphine naloxone, if we look at this threshold for respiratory depression, medications such as Tylenol 3, morphine, Dilaudid, if we keep increasing the dose, we increase the risk of crossing the respiratory depression threshold and people stop breathing, and that's how they overdose. If you look at the yellow line here, buprenorphine and naloxone, because it's a partial agonist, it never crosses that respiratory threshold. We never give doses high enough because there's this ceiling effect because it's a partial opiate agonist. People will not stop breathing on it. This is a slide again just to drive home the safety of buprenorphine naloxone is that really with respect to Ontario deaths, opiate-related deaths, it was essentially found in no opiate overdose-related deaths. So it is a very safe drug to use. The duration of action, the reason why I like to use it, I use it mostly in the emerge. I use it very often in corrections. We use it in our acute withdrawal management, and I use it in my office because it peaks in 30 to 60 minutes. When you see somebody in severe withdrawals for many reasons, I even use it in people who aren't interested in quitting drugs because people often present to the emerge and they're so sick because they can't get fentanyl. I can give them one dose in my emergency room of buprenorphine naloxone in 30 to 60 minutes. Their withdrawals are gone. They're not vomiting. And I've protected them for overdose for up to 48 hours, depending on my dose, from overdosing. Because often if they're in severe withdrawals or if they've been reversed on Narcan, the risk of overdosing when they leave my emerge again is very, very high. It's dose dependent. So giving someone who uses fentanyl a 4 milligram dose of buprenorphine naloxone is going to get you 4 hours. It's not going to last. And then people are going to say it doesn't work. You need to give them higher doses, like more than 16 milligrams. If you give them extended, the release depot buprenorphine, I have patients by their 3rd or 4th injection who can go 6 to 8 weeks between injections because the plasma concentration of buprenorphine is high enough. And at first, some people who are using fentanyl, I have to give them early injections. Sometimes the first couple of months, they get an injection every 2 weeks, but for them, it's a game changer because they're not reliant on taking a medication every single day. And even, you know, it's hard for those of us who have every support in the world, those of us who have a roof overhead to take a pill every day. I mean, it's hard for me to take a pill every day. So I can't imagine, you know, for some people needing to take even a Suboxone tablet every day, let alone, you know, pick up their methadone every day. That's difficult. So that's why the extended release depot has been a game changer for many, many of our patients. It's a partial mu opiate agonist. It has a very high affinity. It sticks to that opiate receptor like crazy glue. It sticks much tighter than most, if not almost all other full opiate agonists. The problem is when it sticks to it, it doesn't stimulate it as much because a full opiate agonist will stimulate that mu receptor fully. A Suboxone or buprenorphine naloxone only partially stimulate it, but it does treat cravings and it does treat withdrawals and it protects them from overdose risk. And it has no euphoric effects. I like to show this. So the first slide is somebody who doesn't use opiates, and that you can see their opiate receptors there, the active opiate receptors in their brain. The second one is someone who uses opiates, the second line where there's no buprenorphine given to the patient. And you can see how many more receptors are active in the brain. They have this upregulation of opiate receptors. The second, where it says, the third line where it says BUP2 shows where if you gave someone a 2 milligram dose of buprenorphine naloxone, where it really only covers about 30 to 50% of the receptors. If you give someone 16 milligrams, that's the last line, you cover between 79 and about 90% of the opiate receptors. So we need to give people higher doses. People worry about buprenorphine naloxone precipitated withdrawal. My argument all the time is The worst case scenario is we have to treat it. And I say this to my patients that if you time it properly, and we're going to talk about this a little bit more, you won't put people into precipitated withdrawal. The thing is, if you use enough buprenorphine naloxone, you will put people into precipitated withdrawal. If you do, you can treat it. It's very, very, very treatable. And this is what happens when you give someone buprenorphine naloxone. It has nothing to do with the naloxone. The naloxone and buprenorphine naloxone is strictly to prevent diversion. The reason why you get this feeling of withdrawal is, here's an example. So the red line is people who are using fentanyl. Buprenorphine is the green line. When you give buprenorphine naloxone, it has a very, very high affinity for the mu receptor. So it'll kick off any remaining opiate. So if you don't wait long enough for people to naturally go into withdrawals and you suddenly kick off that opiate because you've given something that has a higher affinity for the receptor, it's this net effect of a full opiate agonist fully stimulating to them dropping down to this partial opiate agonist. And what happens is, it feels like true withdrawals, but it's different in the sense that it's because you've had this net effect of a full opiate agonist to a partial opiate agonist. It's not an antagonist. It's not putting the brakes on going to zero. It takes time for those receptors to be stimulated by the buprenorphine naloxone. And remember, they don't stimulate them the same. Buprenorphine naloxone doesn't stimulate the receptor the same. It doesn't give you euphoria. So it takes time for those receptors to adjust. So the treatment of precipitated withdrawal, first line is more buprenorphine. I've given people up to 100 and 120 milligrams if they've gone into precipitated withdrawal. And within 2 to 3 hours, it's done. It's over and they feel fine and they don't regret doing it because they so badly want to come off fentanyl. And for some of them, it's almost impossible to get off. There's other things to consider. I find those who use, who want to come off methadone, or those who have been off methadone for 3 or 4 days and want to go on to depot buprenorphine, they can be the toughest with respect to precipitate withdrawal because methadone is very unpredictable and sometimes we need to treat them with opiates. But this is just a case report again of what I just said, that we can manage opiate-induced precipitated withdrawal from buprenorphine and naloxone by actually giving more buprenorphine, and it works very, very well and safely. My talk is about macrodosing today. And the whole concept about macrodosing is if we give people higher doses, we saturate the receptors more. Rather than giving these tiny, tiny doses, we're kicking off a little bit of the full opiate agonist at a time for giving this partial. That we give them a big dose, we saturate it. So we're using larger than standard doses of buprenorphine that effectively treats the withdrawals and reduces overdose and death. There's really 3 case scenarios that we use this for. For people who fentanyl is their drug of choice because they can tolerate, they have a huge opiate tolerance. They're going to tolerate hundreds of milligrams of buprenorphine naloxone. They will not stop breathing. Remember, they're using off-label fentanyl, the most powerful drug, and at the risk of dying almost every day. And many of our patients have overdosed many, many times. Post-opiate, the second case scenario, clinical scenario is post-overdose. We see this in the eMERGE where someone receives intranasal Narcan from a bystander and they go into full opiate withdrawal. Their COWS is greater than 12. We give them a big dose so that we fill those receptors because all with the naloxone, all the opiate has been kicked off. And the other one is the patient's been more than 24 hours after the last fentanyl. When we look at macrodosing, there's a sweet spot. So if you're giving somebody between 2 and 8 milligrams of buprenorphine naloxone and you haven't met the criteria where they're more than 24 hours from fentanyl use, where they have hard signs of withdrawals, or where they have not been fully reversed with naloxone, etc., you're going to give them too small of a dose of buprenorphine naloxone, and you're going to put them in precipitated withdrawal. That's right under the curve. That's 2 to 8 milligrams. If you give them a higher dose, you're going to get displacement of anything that's left, but you're also going to get the agonism of the buprenorphine naloxone because there's going to be enough receptors open. So you want to make sure there's enough of the full opiate agonist off the receptors to then accept, and patients won't feel sick. I love this little demographic here, and that demonstrates why macrodosing and the perfect person for it. And this is many of the patients that we've seen emerge. This is where withdrawal predominates. When you have it where the agonist effect predominates, so someone who still has a lot of active opiate on board, that's when you need to use other strategies. But this is when withdrawal predominates. That's in the person reversed from Narcan. That's in the person that can't get their hands on fentanyl and haven't been able to find fentanyl for more than 24 hours. Those are the patients where macrodosing works amazing for, and the benefit really outweighs the risk. We met with the California Bridge group in Timmins. We noticed that they were doing these macrodosing protocols in California and out of some of their emergency departments. So we met with them and we said, okay, talk us through this. How are you doing this? And so they have some great protocols. So then after we met with California Bridge, and Dr. Sampson and I started doing this here in our own Emerge and realized how effective and helpful it was for patients, whether they wanted to stay on OAT or not. The fact that they were presenting for, was it a medical reason? Were they presenting because they were in severe withdrawals or reversed on Narcan? We knew by giving them a huge dose of Suboxone, it was protective and it was the right thing to do that made them feel better. That we joined with Medifee through Women's College and we developed our own protocol. And I would suggest anyone to go to the Medifee website and look at all the wonderful resources they have. And we have this little sort of pathway protocol to use in the 2 clinical scenarios that I was discussing. It's really interesting now. There's a couple case reports of some places in the States because patients so badly want to stop using fentanyl and they can't wait long enough to get on the extended release buprenorphine and macrodose of buprenorphine, that they're administering Narcan to themselves. And then there's a clinician there giving them a huge macrodose of buprenorphine naloxone. And actually, a funny story, this actually happened in our own Emerge department. We had a patient come in who was using fentanyl and quite sleepy, and she woke up herself and gave herself intranasal Narcan in our Emerge, and of course, felt terrible, was vomiting, diarrhea, and we gave her 32 milligrams of Suboxone, and within 30 minutes, she was better, and she actually entered into our acute withdrawal management bed, and she's still not using today, but she gave it, in her own controlled setting. These are just some more evidence of protocols for macrodosing. Again, 24 milligrams is very, very safe, especially in the emergency department in our hospital. Again, this is just more proof that anywhere between 28 and 32 milligrams is safe. The nice thing is we worry about weights in our Emerge. You give people buprenorphine naloxone, 30, 60 minutes. Patients like this can be in and out of our Emerge in 3 hours and also be connected with resources. It's really fascinating to see. And again, this is another study where they gave doses up to 96 milligrams and people did not stop breathing, people who were using fentanyl. And again, here's another scenario that supporting the theory that macrodosing induction stimulates sufficient opiate receptors to avoid precipitate withdrawals. If we give bigger doses, and this is what I'm going to talk about, Dr. Sampson and I discovered, is if we give bigger doses, people feel better. Oh, geez, I'm almost done here. So we also started a new study with EMS in the field with buprenorphine naloxone, where people get reversed on Narcan and they are given, people are reversed on Narcan and they are given Suboxone in the field, and then they're brought to the hospital. This is the first place in Canada, Timmins is, where our EMS are stocked with it. Just to get on quickly, I have 3 minutes. This is the gist of my presentation. When we started this program in Timmins, the product monograph for extended release buprenorphine naloxone says you have to wait 7 days before you can give Suboxone. Do you think patients can wait 7 days? They can't. And we were starting with, you get 4 milligrams your first dose, 2 milligrams. Day 1, max 12 milligrams buprenorphine max dose. People would leave. They didn't want to stay, and they would never come back for their injections. So over time, Dr. Sampson, I said, listening to patients, listening to nursing staff, seeing the outcomes, we realized we need to just give a big whopping dose. So what we started doing is people would come in, we'd hold them, get them to the 24 hours through giving them other supportive medications, and then we give them a huge dose of buprenorphine naloxone in our beds. And now we're giving them, I'll show you here. And this is just to say that clinical observations support our macrodosing, giving these big doses. And we had to remember this was the urgency of the crisis made us change what we were doing. We had to do this. There wasn't all evidence, but I also say medicine makes evidence. We always talk about evidence-based medicine, but medicine also makes evidence. And we noticed that it decreased precipitate withdrawal. We started noticing if we gave these big doses, and an hour later, we started giving people their extended release injection of buprenorphine. So now what we do, people come in, some people are in our beds for 24 hours only. We hold them, we get them to the 24-hour mark. They have to be in hard signs of withdrawals, tachycardia, diaphoresis, yawning. We give them a huge dose of buprenorphine naloxone, somewhere around 32 milligrams, sometimes up to 50 milligrams for stabilization. An hour later, we give them their extended release, and many patients leave. And I had this discussion with a doc out of, I think it was Ottawa or Toronto this week. Specifically, there's a lot of people living in homelessness who want the extended release injection. I said to her, this is the way you can do it. Get them to come in, give them a big dose, and give them their Sublocade right away. There's zero harm. They're using the most potent opiate and overdosing on this. Buprenorphine injectable will not kill them. So there's lots of evidence now coming out since Dr. Sampson and I started this over 2 years ago that early depot buprenorphine is very, very safe, and it protects people from overdose. And we've had a lot of success with this in our program. And Dr. Sampson and I, this is in the Journal of Addiction Medicine, we actually published 2 case reports of our own cases where we've given people high doses of buprenorphine naloxone, and then 1 hour later, gave them the extended release injectable form, and they remained in treatment because a lot of these patients don't want to stay in hospital and they leave. And we have now some evidence stating that it's just as protective as methadone or Suboxone. Anyways, it was only 20 minutes and that was very quick, but thank you for listening. And I think I just went over by a minute, Nikki.
Yes. We can take any questions now for Louisa. Oh, here's a question. Do you worry at all about the big spike in serum bup levels in the 24 hours after administration?
So my argument again is what I said. What are you afraid of?
I guess they're afraid of overdose.
But what did I say? Buprenorphine, naloxone. Buprenorphine is a partial opiate agonist. They will never stop breathing. They can't. It's impossible. It will never cross. There's no worry. We have done this procedure in well over 300 patients. I have probably done this, including my outpatient clinic, in hundreds of patients. Buprenorphine is a partial opiate agonist. They're using fentanyl. That's how I say to people, they're using the most potent opiate in the world, pretty much. That stops them breathing probably multiple times. Bup won't be.
Okay, there's a question about what about in the outpatient setting? How does your procedure different?
Yeah, so it's a little bit different, of course, because it's not as controlled. So what I usually say to my patients is I give them a prescription for 32 milligrams of buprenorphine naloxone. I write them a script. I say, go pick it up at the pharmacy. I'd say, make a plan. So you're going to stop using fentanyl at 9 in the morning. And by the next day at 9 in the morning, if you're feeling terrible, they know how terrible, take the full 32 milligrams, come see me in my office, come see me at the hospital, come see anyone at the hospital, because that's the way our program works now. And we will give you your depot buprenorphine naloxone. No naloxone, depot buprenorphine. And that's how I do it. Some patients need to take that 32 milligrams at 4 a.m. And my office is not open, but I make sure they have it. The other thing I do is I actually have some buprenorphine naloxone at my office, because I've had patients walk in off the street in severe withdrawals, asking for help. And I just give them a 32 milligram dose right in front of me. And I often use somebody else's depot buprenorphine. I give them somebody else's, and then I just replace that with theirs.
Question about people who are withdrawing from. Do you ever give benzos also on top of the buprenorphine?
Yeah. Yes. So if people do suffer from withdrawals, the problem is usually the benzo withdrawals associated with the contaminated supply often happens a couple of days after. So when I see them that first day, it's not really much benzo withdrawals, but we follow them. We see them in a couple of days, then at 7 days, then at 2 weeks to see how they're doing. And if it is for sure, we add a little bit of diazepam. And the biggest side effect people feel is fatigue. But I'll tell you, in my patients who use fentanyl, they never feel fatigue from buprenorphine injectable. But those who might use Percocets or morphine, or who use codeine, often will feel a bit fatigued. It's usually for about 3 days, and then they're fine after.
Okay, thank you so much. I think we're out of time, but we will come back to Louisa, when we have our panel discussion at the end. Thank you so much. So next, I am pleased to introduce Dr. Samantha Young, who is a general internal medicine specialist and substance use physician at St. Paul's Hospital in Vancouver. She's a PhD candidate in the clinical epidemiology and healthcare research at IHBME at the University of Toronto, a Vanier Scholar, and a BC-CSU International Collaborative Addiction Medicine Research Fellow. Her research focuses on the pharmacologic preferences of people who use opioids. So thank you, Sam, and please take it away.
All right, thanks so much, everyone. I'm really pleased to be here to talk about this opioid agonist therapy in the context of a benzodiazepine contaminated, unregulated opioid supply. I will say I was a little apprehensive about talking about this because it really is quite an emerging area, really largely evidence-free zone, but we'll see what we can do. So I don't have any disclosures of commercial support. I have no other disclosures to mention. I will be discussing an emerging area of care for people who use opioids, for which there really is minimal evidence. Everything you see that's cited, I'll try and cite evidence whenever possible, but anything that's not cited, you can assume to be based on my own opinion, based on my own clinical experience that's framed by my own values, my patient population, and discussions with other prescribers. So for context, I am a substance use physician. I work in the inpatient and outpatient rapid access clinic at St. Paul's Hospital, which largely serves Vancouver's downtown east side neighborhood. I'd also like to acknowledge that I'm a settler on this land where I live and work and play, which is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So I'll use the term non-medical benzodiazepines, which is also the term, there's a Canadian Centre for Substance Abuse document that talks about non-medical benzodiazepines in the unregulated drug supply. So we'll kind of talk about what non-medical benzos there are and where they are, what the concerns might be, what other prescribers are doing, and that is based on an unofficial crowdsource of people I know. What should we do? And that, again, is my own opinion. And where do we go from here? So what are we exactly talking about? So when we think about what exactly are these non-medical benzodiazepines that we're seeing emerge in the toxic drug supply, they're often things that are medically available but have been diverted for non-medical purposes. That's actually a pretty small proportion of what we're seeing. More so is things that have been developed but not brought into the market in Canada, or things that are newly synthesized or designer drugs. Many of these substances have never been tested in humans or animals. So just to give you some reference, I'm not sure where everyone practices, and there's not great drug checking data in across Ontario, but out of Toronto, the most recent statistics that just came out a couple days ago show that out of 149 samples, 52% of those fentanyl samples contained at least one benzodiazepine-related drug. The most common of that was bromazolam, which you've probably not heard of because it is not used medically. You'll see, like, sometimes you think it might be something that's used medically, like something like clonazepam, sounds like clonazepam, but is a slightly different entity. And then in BC, where we have a bit more volume in terms of drug checking data, up until April of 2023 this year, they tested just under 4,000 samples, and 48% of opioid samples contain benzodiazepine. So you're getting a sense it's kind of about 50% of what people are using. You can see, again, just that the trend in benzodiazepines over time. So really, this is like an emerging phenomenon that does not seem to be going away. I just wanted to talk briefly. I mean, we could talk about many different of these non-medical benzos, but I'll just talk a bit about atizolam, because that may be one that you've heard of, because that often circulates in the news a little bit more. But atizolam is actually a phenodiazepine, so it's chemically related to a benzo. For all intents and purposes, could be considered a benzodiazepine, but it's not actually a benzodiazepine. It is a full GABA-A agonist, though, similar to benzodiazepines, acts on the GABA-A receptor. It's hepatically metabolized. It has quite a long life relatively of an average of kind of 12 hours. And it was patented in Japan, and I think it's still available in Japan and Italy, but it's not licensed for use in Canada or the US. And so there's some data out of BC to say that it can be detected by benzodiazepine test strips, but it's not that sensitive, and definitely possible to have a false negative. For all those other, there's many non-medical benzos that are in the supply, some of which will test positive for benzos. I'd say, clinically and anecdotally, many of the urine drug screens that we do will test positive for benzos. So I'm not sure exactly what benzos those are, but it shows up. But if you have a negative urine drug screen for a benzo, that does not mean that there's no non-medical benzos in there. So really, why are we concerned about this, and why should we be concerned? So say that the concerns, I think, fall into kind of three big categories. So how does this affect people's overdose risk and response? What are the side effects of these contaminants? And what are the withdrawal? And just as a side note, I just use the term contaminant, and it is, in many ways, it's now something that's contaminating the fentanyl supply. But I think, there's not a lot of data on this, but, many people are now deciding whether they want to search out, benzodope or trank dope or whatever you want to call it, or not. And some people do find positive effects for them, and are choosing to use that, and some are specifically trying to avoid it. But in many cases, it's unavoidable since it's so prevalent. So in terms of overdose risk, does using these substances that are contaminated with non-medical benzos increase your risk of overdose? I think, there's lots of data from the kind of non-contaminant benzo, kind of just normal benzodiazepines, that yes, it would increase your overdose risk. And benzos in literature, just in benzodiazepines, are associated with a dose-dependent increase in overdose when combined with opioids. And both of these have kind of synergistic depression of the CNS and respiratory function. There is a paper that shows that the risk is higher in combination with methadone compared to buprenorphine. And so that was for people who are using non-prescribed benzodiazepines, but those are more likely to be kind of, your typical benzodiazepines that we see, alprazolam, clonazepam. And that would make sense in the context of methadone being a full agonist. But we don't actually have that data kind of in the current era and climate. But I think it's important to go back to this idea behind benzodiazepines being, increasing overdose risk was the rationale behind the now obsolete CPSO methadone guidelines that would recommend lower starting doses of methadone and potentially a more cautious up titration in people using benzodiazepines. And so we'll come to it at the end, but I think it's important to just stress that context no longer exists. So if you look at coroner data, the number of drug deaths, you can see fentanyl kind of starting around when this crisis has emerged, is been very, very commonly, up in the 80% range of all overdose deaths. But we can now see that benzos are really starting to take off now. 28% of overdose deaths in 2022 contained a benzodiazepine. So this is definitely a problem that is emerging and causing, it needs to be looked at. So in terms of, not just increasing overdose risk, but how do we respond to overdoses? And so, this has become a big topic of discussion within, centers and places that reverse a lot of overdoses. So overdose prevention sites, emergency departments, because these overdoses are different. So the effects of non-medical benzos won't be reversed with naloxone. They're not opioids. So someone could be, having an overdose from an opioid that's contaminated with a benzodiazepine. You give naloxone and they're not waking up. So, it has been brought up. So flumazenol is the kind of antidote to benzodiazepines, and it can reverse the effects of atezolizumab and non-medical benzos. And so there's been, it's often asked when discussing this topic, should we not be giving flumazenol? And the recommendations of a document and manuscript by a group out of the BC is that flumazenil should not be used in the treatment of suspected benzodiazepine or atazolime overdose because it's associated with ventricular dysrhythmias and seizure. And the seizures that occur after flumazenil can be very difficult to treat. So you can imagine, much like we think about the phenomenon of precipitated withdrawal, you, by giving flumazenil, are putting someone into precipitated benzodiazepine withdrawal. And if they've been chronically exposed to benzodiazepines, they are then at risk of all the things that go along with benzo withdrawal, including seizures. So really the mainstay, if someone's getting naloxone and they're not waking up and it's a suspected non-medical benzo kind of related phenomenon, is supportive care with oxygen if needed, and then giving time for it to wear off. In terms of side effects of non-medical benzos, so they are similar to benzodiazepines: sedation, unsteadiness. Memory loss is something that's been brought up a lot. There's a Crackdown episode about kind of benzos in the drug supply and talking about the memory loss that can occur. And so you can imagine not just the fact that someone maybe doesn't remember, but potentially at higher risk of sexual violence, assault, theft. And I hear that from clients sometimes about using these substances and then losing time and losing things. And then benzodiazepine withdrawal. So I think that's a big concern for all of us, for people who treat this, for people who use drugs. And so benzodiazepine withdrawal is not a comfortable thing to go through, I would imagine. And it's also potentially dangerous. So, there's those symptoms of anxiety, insomnia, tremors, muscle spasms, delirium, and nausea. And, it's important to note that a lot of this is going to be subjective. So tremors, I mean, you can look at old literature on benzodiazepine withdrawal and how it's described, and often described somewhat similar to alcohol. But I have found that I don't find that the tremors are as prominent potentially as with alcohol. And so a lot of it becomes more subjective. And how do we then decide who to treat and who not to treat? So seizure is really, I think, one of the biggest things that we're concerned with. And so again, taking literature from benzodiazepines, I think I forgot the citation on this page, but it's all at the end, but has been reported in cases of daily use, like less than kind of the 2-week mark. So you can develop quite dangerous tolerance and at risk of withdrawal within even fairly brief use. And it can occur with relatively low doses. So even doses of benzodiazepines that are considered clinically indicated. Again, this is a really challenging thing to do, because when people are using unregulated drugs, non-prescribed drugs, like, we have no idea what exactly the amount of benzodiazepines that someone's using. What are they using? Has all of their substance been contaminated, or are they just sporadically using? So it really is a bit of a guessing game, and trying to speak with patients and trying to understand what their patterns of use are to see if they're at risk of this. The time between the last intake and the occurrence of seizures for benzodiazepines in general seems to be related to the half-life. So a shorter half-life drug, more likely to experience seizures early on versus a long half-life. Again, with the current state of the completely unpredictable and toxic drug supply, it's really hard to know what people are using. And so, just to say, like, there is extremely minimal research on the risk of seizure and just in general what to do about non-medical benzos in the opioid supply. But we just kind of have to assume that some similar principles apply, where people chronically using benzodiazepines, whether it's, in a non-prescribed, unregulated drug supply, have some risk of developing withdrawal that could be dangerous. So what are prescribers doing? And, I think it's very variable. So I've heard a bit about some people using prescribed benzodiazepine tapers, and that's to prevent the risk of relapse when initiating opioid agonist therapy, or if, in the context of someone coming off of an unregulated supply, or to prevent seizure and withdrawal. So I think those are kind of like the two main indications: is you've been using this substance every day for a long period of time, if you're going to stop and start having bad benzodiazepine withdrawal, even if I've, treated your opioid withdrawal with opioid agonist therapy, whether it's methadone or buprenorphine or what have you, you're still at risk of then being, feeling like you need to use the unregulated supply because you're not having access to the benzos. And then also, of course, if someone's at risk of seizure, we want to deal with that. And I'd say it remains very prescriber and patient dependent. A lot of what I've heard people doing are more short course tapers, kind of similar to what we would do in the context of alcohol withdrawal, except not using a CWA protocol. I mean, you could theoretically try and use a CWA protocol like scale in the hospital, but that would again be very kind of place dependent, nursing dependent, how people could handle that, and how comfortable you would feel that a subjective or objective scale would capture the withdrawal that you're looking for. So a lot of what I see is things like diazepam 10 TID for a day, then diazepam 10 BID for a day, and then diazepam 10. People do longer tapers for sure. Many of you who have done benzodiazepine tapers may be familiar with the Ashton protocol, which is a much longer protocol. And typically, when doing outpatient benzodiazepine tapers, I do much longer tapers. But as a general sense, this is often what I'm doing if I'm prescribing benzodiazepines. But again, there's no right answer at this point. I think this pharmacologically is kind of based on the idea that if someone's stopping using, that this diazepam, which is a bit more long acting, is enough of a taper to get them out of that risk of severe withdrawal, whether or not it manages the cravings and kind of subjective withdrawal long term. Again, it kind of remains to be seen and would have to be a conversation with that client and potentially considering other medications to manage some of the subjective symptoms as well. What I think about when I'm prescribing benzo tapers is like, so firstly, setting. So, for example, if I was treating someone in a locked psychiatric unit, I may be more likely to prescribe benzos. They're probably already getting benzos if they're in that setting, but trying to make sure that they have that because I know that they're not going to be able to access other non-medical benzos otherwise. But for example, if someone's admitted to the inpatient service and their kind of goal is to cut down or stop using, but they're probably going to continue to use a little bit of down or unregulated opioids as well, I probably wouldn't prescribe it given the weighing the risks and benefits of me prescribing something on top of the unknown substance that they're already taking. If someone's goal is to stop using altogether, they're starting on a form of OAT where I think that's very likely that they are going to all of a sudden stop using. So something like a Suboxone induction, a Sublocade induction would be more likely to consider prescribing. And what I think the risks of prescribing are also, do I think they're at high seizure risk? Have they had seizures before? All of that weighs into it. And then, realistically, I think based on the title of this conference, I think many of you are primary care, or most of you are primary care physicians. And actually, I think that is often one of the barriers I have in my own practice is that I don't follow people longitudinally very often. I'm an internist. I see people, in the hospital briefly or do the inpatient service, and then they're leaving. So, you do have the opportunity, if this is your own patient, to form, a relationship with them and understand their trajectory, whether they've tried to stop in the past, and this has been a major driver to resume use. Maybe considering doing a benzo taper and just, I always try and have some sort of understanding of what they could expect from me and what I could expect from them when I'm prescribing a benzodiazepine for long term. And really the goal would be to kind of slowly replace what they've been using in a tapering fashion to enable them to come off of it in a safe way. I mean, there are many other indications for benzodiazepines in different settings, but that's kind of what I see the indication being in this context. So what do I do? Again, like I don't work in medical detox. Most of my patients are not in kind of a closed setting. Based on the goals of what many of my patients have, many are kind of in that stage of, I want to cut down. I'm starting on methadone. I'm not seeing myself stopping using altogether. And so to me, at that point, kind of pharmacologically, they're going to self taper down if they're going from using a ball of fentanyl a day down to a couple points over the next couple weeks as their methadone dose comes up. They are sort of self tapering down on the benzos regardless. And so that would help to reduce the risk of severe withdrawal anyway. So it ends up being that I don't commonly prescribe benzos for individuals. I think in detox settings in Vancouver and maybe elsewhere, I'm not as familiar with what's going on outside of the Vancouver Center, but I think it's fairly commonly done in detox, where it's kind of that similar protocol of a short course, potentially a slightly longer taper as it goes on. And no, I'm definitely more like if someone is having objective signs of withdrawal, would not hesitate to manage that because they are at risk of complications. And if someone's coming to me and starting on OAT, and then as Louisa was saying, you start someone on Suboxone or Sublocade or whatever form of OAT, you're probably not going to start to step into withdrawal right away, but maybe in the next 24 or 48 hours. And so if someone's come back and said, I feel fine from the opioid withdrawal perspective, but I'm really struggling with benzo withdrawal, then, considering a prescription at that point seems quite reasonable to me. And I will say, like, I have seen people have seizures, and there was I hate to rely on anecdotes, but unfortunately, that is really what we have, and I think this really does need to be studied. But there was someone who did a home Suboxone induction and was admitted to medicine with altered level of consciousness after a seizure, and in the end, after a full workup, which again has many kind of risks as well, got a lumbar puncture, got all these you know interventions, and in the end the diagnosis was that it was probably a benzodiazepine withdrawal seizure from the unregulated drug supply, and going from using daily to all of a sudden going on to Suboxone and using nothing. So I do think that we want to be prudent in when we're prescribing, but also not so afraid to prescribe that we're potentially causing harm to people. So I'm working on my own internal struggle of like when to prescribe benzodiazepines and how to do this. And hopefully soon we'll have better evidence to guide us. So what do I think we should do? I really think this needs to be studied a little bit better, and I'm sure that will come. I think we need to really listen to people who use drugs who are talking about this, and listen to people when they're saying, I'm taking my methadone or my slow release oral morphine, and I'm feeling bad withdrawal, and that this probably is a phenomenon that's happening. Definitely counseling patients with the risk of overdose and withdrawal from non-medical benzos, and to again encourage more frequent follow-up. So potentially, normally I would prescribe a Suboxone induction or buprenorphine naloxone induction, sorry for using the brand name, and say come back in a couple days. But I might now say come back in a couple days, or you come back sooner if you're really not feeling well, and these are the reasons why I'm concerned, and there's lots of benzos in the supply. And then I just want to say, like, I think, feel very strongly that we should not be restricting doses of methadone or forms of OAT for people using fentanyl with non-medical benzos. So if someone is using like a supply of train or with non-medical benzos in it, and they want to go on methadone, I would think that sounds like a great option, and would not be saying, really, because you're using this, you're exposed to benzos, you should be on buprenorphine naloxone, or we should restrict your doses a little bit or titrate more slowly. It's kind of a circular argument, right? Like they're using it because it's in the supply of the thing that they're trying to get off of. So we really just want to help support people to come off of that, would be my own approach to this. So thank you, and happy to take any questions now or at the end.
There's a question in the chat. What are your thoughts around a benzo taper for people who have been prescribed them long term, is there any potential long-term effects on the GABA receptor? Is there potential for full recovery? And if so, how long would that take typically?
So I think that's like a great question. That's a completely separate to me topic and issue. Like I assume you're talking about someone who's it feels like a prescribed benzodiazepine. So I mean, again, like that was kind of not the purpose of this talk, but in general, like for someone like that, kind of prescriber dependent, like you'd form a relationship, consider the Ashton protocol. But this is more about people who are inadvertently or potentially now intentionally using benzos in the context of like using the unregulated toxic drug supply. So I don't know if that answers your question at all, but I'm not sure that seems like maybe a slightly separate issue that might take more time to delve into fully. But if you want to look up the Ashton protocol, like it has a whole protocol in it. It takes weeks, long time.
Another question. I find differentiating what people are experiencing, benzo versus opiate withdrawal, can be difficult and subtle unless they're presenting with tremors, hallucinations, etc. Trying to pick up on folks who describe a lot of anxiety or restlessness to see if there could be benefit from benzos.
Yeah, I totally agree. I think it is really challenging. Like the benefits sometimes of me being in a setting like the, particularly in the inpatient setting, is I can often give people lots of opioids very quickly. So even if they want full agonists, can give them a bunch of, short acting hydromorphone plus methadone or plus slow release oral morphine, or kind of really like give them a good dose of opioids to the point that I'm kind of confident that those symptoms shouldn't be due to opioid withdrawal. And assuming they're not using any other substances like alcohol or something, they're still having ongoing symptoms, then more likely to think that it's benzo withdrawal. I know that you probably practice in the outpatient setting, so it is really challenging. But again, like I think we know that there are risks of combining benzos and opioids, and I'm not quite there yet in my own like process of things to start prescribing people benzos when I know that they're still using. So if someone is having some of those symptoms as they're cutting down, maybe trying to talk about like other ways to manage those symptoms, other adjuncts that might be helpful, or trying a short course of small dose benzodiazepines to see if that helps. But usually just trying to be like more confident that I've done the opioid piece first, which can be hard. But the risk of kind of like severe benzo withdrawal, if they're still using, is not high. But any current research, I don't actually know. I'm sure there's probably people looking into this, but I don't really know. But it's very challenging.
Thank you so much, Sam. Okay, so we are all going to break now for 10 minutes. So please join us back at 3:30 when we're going to hear from Dr. Olivia about the fentanyl patch program. Thank you. For those of you who may be joining newly, this is our panel OAT in the time of fentanyl. After we hear from Dr. Brooks, we're also going to have a panel discussion. If you have questions throughout, you're welcome to put them in the chat and I will do my best to moderate. So I want to introduce Dr. Olivia Brooks. She completed her family medicine residency at the University of Ottawa and her enhanced skills in addiction medicine training at the University of Toronto. She completed the International Collaborative Addiction Medicine Research Fellowship with the British Columbia Centre on Substance Use. She works as an addiction medicine consultant at St. Paul's Hospital in Vancouver, BC, as a family physician on the downtown east side with the Portland Hotel Society and with BC Corrections. So thank you, Olivia.
Great. Thanks, Nikki. So I'll be talking to you about the fentanyl patch program today. I want to start by acknowledging that I'm coming to you from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations in what is now known as Vancouver. As Nikki mentioned, I work as as a family physician at the Portland Hotel Society, or PHS, under the leadership of Christy Sutherland, who you heard from earlier today. And this is where the fentanyl patch program was born. And I also work as addiction medicine consultant at St. Paul's Hospital. So in both of these roles, I do a lot of fentanyl patch prescribing for opioid use disorder, which I'll be talking to you about today. Of course, this is all off-label use of the fentanyl patch. In terms of my disclosures, they're listed here. So as I mentioned, the fentanyl patch program was created and developed at PHS, and the program began in July 2019. And what we're doing with the fentanyl patch is basically what we're doing with every other form of OAT. We're delivering long opioids in a long-acting form so that we're able to treat people's cravings and withdrawal so that they can achieve their substance use goal, whatever that may be. At our clinic, we offer the fentanyl patch alongside all evidence-based forms of OAT. So methadone, slow-release oral morphine, and buprenorphine naloxone. Initially, we restricted the fentanyl patch program to patients with opioid use disorder and chronic pain who've been unsuccessful in achieving their substance use goal with other forms of OAT. As the program's expanded, our eligibility has also expanded as we now have more avenues to get the patches to patients, so can accommodate more. The PHS protocol for the fentanyl patch program is constantly evolving. We're continuing to develop it under Dr. Sutherland's leadership. Our protocol was developed into another protocol that the BCCSU, or the British Columbia Centre on Substance Use, published. So what I'll be presenting today is primarily from this guideline so that you have something to cite if you're looking to develop a program in your own community, and also a little bit peppered in of what we're doing at PHS now. So in terms of the eligibility as it stands now for the fentanyl patch program, you need to have opioid use disorder, be fentanyl tolerant, and have had unsuccessful attempts at stabilization on other forms of OAT. The major contraindication to the fentanyl patch is any new or evolving clinical condition that could be worsened by high-dose opioids. So if you have severe respiratory compromise or hepatic failure, so fentanyl is hepatically metabolized. So if your liver is not working, you're running the risk of overdose and sedation with that. So avoided in that population. There are other populations that we're a little bit more careful with. So if someone currently has an injection-related infection, so if they currently have bacteremia, for example, any coagulation disorders, recent head injuries, concurrent sedative use, as you just heard from Sam, most of the drug supply in Vancouver has benzodiazepines or benzodiazepine-like drugs in it. So that's not a contraindication, or it doesn't really affect us that much. It's more of its prescribed use or something outside of what's seen as a regular contaminant in the drug supply, and pregnancy as well. So again, it doesn't preclude it. These are just patients we keep a closer eye on. The other thing to keep in mind when we're looking at eligibility for the fentanyl patch is some significant drug-drug interactions. So certain ARVs can be quite high risk with the fentanyl patch because they increase levels of fentanyl quite significantly. So those are ritonavir, Stribild, Genvoya, and Prescobix. Most of the modern ARVs don't have an interaction with fentanyl, but these ones are ones you want to be mindful of. If someone is on these ARVs and is stable on them, they have regular adherence, there's no issue with the fentanyl patch. You would just start at a lower dose and go up a little bit more slowly, knowing that the effective dose that their body is seeing is higher. If someone has intermittent ARV adherence and they're on one of these agents, though, they're probably not a great fentanyl patch candidate because the plasma levels of fentanyl are going to be going up and down, which might make it a dangerous option for them. The other thing to be aware of is the risk of serotonin syndrome with serotonergic agents. So in particular, we worry about things like linezolid, which works kind of like an MAOI, and TCAs at higher doses. For the TCAs, we generally just monitor. If someone's on linezolid and there's no other antibiotic options for them, usually I rotate them to a different form of OAT, and we'll go over how to do that until their linezolid course is finished, and then put them back on the fentanyl patch to reduce that risk of serotonin syndrome. So briefly about the pharmacokinetics of the fentanyl patch. So because it's a patch, the onset is quite delayed. So it's 12 hours after the patch is applied to the skin. It peaks anywhere from 24 to 38 hours after the patch is applied, and that varies based on the dose. Not in a dose response way, just totally randomly. The half-life of the fentanyl patch is 20 to 27 hours, and that's different from a fentanyl infusion. And that's because when fentanyl is delivered in a patch form, it forms a depot in the skin, and that's what gives it that longer half-life. Steady state is reached after 4 to 6 days on the fentanyl patch. So in terms of how the patches are administered, at our clinic, we administer them on Mondays, Wednesdays, and Fridays. If your clinic has the capacity to do every 3-day dosing, then that can be done. So that includes the weekends. Sometimes if people have an inadequate response on every 3-day dosing, they can move to every 2-day dosing. And this would be usually in people with low amounts of body fat. So like we talked about, the fentanyl patch forms a depot in the skin. So if you don't have a lot of subcutaneous fat, you have less of a depot there. So may require more changes more frequently. Initially, all of our patch changes were done in our clinic by our nurses. Every patch was dated, signed, and transparent dressing was applied over top, partly to reduce tampering, but also really to help the patches adhere to the skin. Patch sites are rotated so that the same site's not used within 7 days. The only exception to this is, let's say a patch fell off, and when you're replacing it within 24 hours of that patch falling off, then the same site would be used in that situation. We've now expanded our program to have a pharmacy option. And this has really increased our capacity in the program. So the way that the pharmacy program works is either the pharmacist applies the patches directly to the patient, so applies and removes, or the pharmacist witnesses the patient removing and applying the patches, or there's a patch for patch exchange. So as you can imagine, our patients have a lot of trauma. Sometimes they don't want like a male pharmacist doing their patch changes or watching them. And also depending on the person's body, they may put the patches like on their upper thighs or on their chest. So there may be sensitive areas where a patch exchange is more appropriate and preferred by the patient. The pharmacy notifies the prescriber if the person has missed more than 5 days since their last patch was applied, then our missed dose protocol would kick in. If there's been any tampering with the patches, or if there's a discrepancy in the number of patches that are returned. So either none are returned or fewer than were dispensed. If that's the case, this would go towards diversions. So our program allows 3 diversions before people are removed from the program and rotated to another form of OAT. We do know that patches fall off. Some people just based on their skin or their sweatiness or the weather. So patients are advised to call the clinic immediately if this happens and to keep the patch so they can bring it in at their next patch change. I will say diversion is relatively uncommon in our program. People really seem to benefit, and this hasn't been a major issue for us. In terms of doses, if people we don't have a great sense of their tolerance, maybe they have a hard time quantifying their use, we start them at 25 to 50 micrograms per hour and increase them weekly by that same amount. If people have known high tolerance, and this is a little bit at prescriber discretion, most of us would sort of say using over a quarter gram a day of fentanyl. Then we start them at 100 to 200 micrograms per hour. And after every 2 consecutive patch changes, so that's either every 4 to 5 days if you're on a Monday, Wednesday, Friday protocol, you go up by 50 to 100 micrograms per hour. In terms of the maintenance on the program, there's no max dose written into the fentanyl patch program. We want to titrate the dose until people don't have cravings or withdrawal and they're not being sedated from the dose. Above 1,000 micrograms per hour is our sort of watchful dose in our protocol. So at this point, you might consider discussing with another physician whether or not this patient is actually benefiting from further increases. Anecdotally, patients typically stabilize on doses around 1,000 micrograms per hour, so anywhere between 800 and 1,200, and that's about 3,600 MEQs. So as you can see with the fentanyl patch, a main benefit of this program is we can get to really high doses, which our patients with this very high tolerance need, that are difficult to achieve with our other agents. Like imagine so many capsules of slow release oral morphine to achieve that same dose. So in terms of our missed dose protocol, we do have one for the fentanyl patch. If someone misses more than 5 days, that's when it starts to kick in. So 6 or 7 days, you reduce the dose by 30%, 8 or 9 days, reduce by 50%, and 10 or more days is a restart. You start counting missed days the day after the first patch was applied. This is something that the PHS group is working with actively to try to make sure that we are not being overly cautious and reducing people's doses unnecessarily, because this can, as you can imagine, be very destabilizing for patients. So in addition to the regular titration, like starting at sort of 50 to 100 micrograms per hour or more, there are other ways to get onto the fentanyl patch, which we'll talk about, that are a little bit more efficient. So you can rotate from other opioids onto the fentanyl patch. So we'll go over 3 examples of this, using slow release oral morphine or SROM, using short acting opioids, and methadone as another example. So we'll start with rotation from slow release oral morphine. So if we look at the dose conversion of fentanyl patch to morphine, there's usually a range. You'll usually see these in tables. The middle of that dose range is a 25 microgram per hour fentanyl patch to 90 milligrams of oral morphine. And that's a total daily dose we're looking at. In these conversions, there is no dose reduction for incomplete cross tolerance. So that's unique to fentanyl patch conversions. Every other opioid, you need to do that, but it's taken into account in this ratio. The other important nuance when you're doing these kind of rotations is that the fentanyl patch onset is 12 hours after the patch is applied. So that means that you're going to apply the fentanyl patch in the afternoon prior to when your SROM is discontinued, because we want the fentanyl patch to be active when the body's expecting that next SROM dose. If you apply the patch the morning that the SROM is stopped, the person will be uncomfortable all day while they're waiting for that fentanyl patch to kick in. When you're doing this rotation, the BCCSU guideline recommends rotating up to a maximum of 300 micrograms per hour of fentanyl patch. That's about 1,000 MEQs. So if someone was on 2,000 of SROM, you would convert the first 1,000 into fentanyl patch. They would remain on 1,000 of SROM plus 300 of fentanyl patch. And then after steady state is reached, so after about a week, you would rotate the remainder. In practice, I don't have a max dose for my rotations. I just do the math and it's been fine. So if we look at a case example of this, so let's say you have a patient, they're on 900 milligrams of SROM. They have difficulty adhering to daily witnessed ingestion. That's made titration a barrier and has made retention on SROM and methadone a challenge in the past. So they're interested in rotating to the fentanyl patch for the 3 times weekly dosing. And this is actually something we see quite commonly. It's so much more convenient for patients, so it can be a real incentive to be in the program. So if we do our math here, we would convert our 900 of SROM using that 25 microgram per hour fentanyl patch to 90 milligrams of morphine. And from there, we get a 25 microgram or 250 microgram per hour patch. So on the Monday morning, they're going to get their SROM dose of 900. That same afternoon, the fentanyl patch, 250 micrograms, will be applied. The next morning, Tuesday morning, no more SROM. The fentanyl patch remains on and will be changed on Wednesday. So next, we'll look at rotating from short-acting opioids. So it's same dose conversions because we're looking at total daily dose, so doses within the 24-hour period. So like we talked about, 25 of fentanyl patch to 90 of morphine, and that's also to 18 of hydromorphone, that same ratio. Again, you don't need to do a reduction for incomplete cross tolerance. One thing I will say about short-acting opioids is I use this when I'm on the inpatient setting where I can confirm ingestion of those opioids. The fentanyl patch is quite dangerous in overdose. It's so long-acting, it forms a depot in the skin. So I need to confirm that they can tolerate that dose. So if it's not witnessed, if I don't know for sure that they've gotten it, then I wouldn't rotate that into the patch. So for our risk mitigation prescribing, I don't take that into account in the patch rotations because I can't confirm the person has had it. So same sort of idea with your short-acting opioids, keeping in mind that your fentanyl patch is going to start 12 hours after it's applied. The half-life of your short-acting opioids is 4 hours. So for that reason, you're going to continue your short-acting opioids for 8 hours after your fentanyl patch is applied. So there's going to be that 8 hours of overlap. And then at that point, you can stop them. Your fentanyl patch should be kicking in by the time that last dose runs out. This same idea can be applied if someone is on IV short-acting opioids. You just half the ratio. So 25 microgram per hour patch would be 9 of IV hydromorphone or 45 of IV morphine if you're doing the total daily dose. So we'll move on to methadone. This one's a little bit trickier because there's no reliable dose conversion between methadone and fentanyl patch. So you cannot safely directly convert between methadone and fentanyl patch. So we have 2 ways of approaching this. Let's say if someone is on methadone and wants to switch to fentanyl patch. The first is doing a cross titration. So you'd reduce your methadone dose by 10 or 20 and increase your fentanyl patch by 25 or 50 micrograms per hour. And you want your methadone dose decrease to take place the day after your increased fentanyl patch dose is applied, again, because of that delayed onset. The second option, which is more efficient, is rotating someone's methadone to SROM and then to fentanyl patch. So methadone to SROM dose conversions, or to methadone to morphine in general, dose conversions vary based on the dose, but the ratio is about 1 to 10 when we're looking at doses used in opioid use disorder, so doses above 40 milligrams of methadone. So if we look at a case example of this, say you're on the inpatient side, a patient comes in, they're on 120 of methadone, but their QTC is 600, you've corrected their electrolytes, you've checked for other offending medications. It's legit. It's probably the methadone. So we need to rotate. So first thing we're going to do is rotate our methadone to our SROM. So that's using a 1 to 10. And again, with all of our opioid rotations, except for fentanyl patch, we need to do a reduction for incomplete cross tolerance. So we're going to take our 120 of methadone. That's going to become 1200 of SROM, and reduced by 25% for incomplete cross tolerance, you get about 900 of SROM. You're going to maintain that SROM for 5 days to let that methadone wash out. Then, once that's the case, you can then convert your SROM to the fentanyl patch using the ratios that we already discussed. So this is how that looks in sort of a graphic form. So day 1, they come in, they're on methadone 120. Then they have 5 days of SROM 900. On day 6, they get SROM in the morning, fentanyl patch in the afternoon, and then day 7, all the oral agents are stopped. They just remain on the fentanyl patch. So your end goal is fentanyl patch monotherapy. The only exception to this is if someone is using the fentanyl patch as their long-acting OAT bridge and when they're on IOT. If for some reason you have a very exceptional case and you want your patient to stay on their oral OAT plus the fentanyl patch, it's just important that you don't increase the dose of the oral OAT until they're on a stable fentanyl patch dose for a full week. Again, because we want to see the fentanyl patch dose at steady state before you're adjusting any other opioids. So in practicing prescribing the fentanyl patch for a while, these are a few pearls and pitfalls that I've encountered. So the first is that the patch can be really irritating to the skin for certain people. So one way around that is spraying a fluticasone puffer onto the skin prior to the patch application. And that can really help reduce the itchiness. This applies to all patches. So nicotine patch, this is also off-label use of the puffer. But this is a better method of using it than, let's say, using like a hydrocortisone cream, because the cream will affect the absorption of the patch and also the adherence. So the fact that the steroid comes as a powder is really handy. So next, when you're changing the patches, always wear gloves. And if your skin is exposed to fentanyl patch, rinse it off with cold water. Don't use soap or hand sanitizer because that can actually increase the absorption of the fentanyl in the skin. If you're trying to increase the patch adherence to somebody's skin, this can be improved by holding your hand over the patch for 30 seconds after it's applied to really help it stick. And then that overlying transparent dressing can also really help. And that's really important if someone is a little bit sweaty just in general, or if it's the summer, these heat waves, we were having a lot of patients having issues with keeping those patches on. So those extra dressings on top can kind of help get them to stick. It's important to counsel patients that heat can increase the absorption of the patches, so they shouldn't put heating pads on them. Even vigorous exercise can also increase the absorption of the patches. The biggest downside of the patches, aside from the environmental issues with lots of plastic, is that patients don't like being covered in plastic. So you can imagine if you're stabilizing on 1,000 microgram per hour of fentanyl, that's like half your back is covered in patches. It's 10 patches. So people love the program. They've done really, really well on it. But this is something that patients do say is the plastic is a bit of an issue. So the limitations of our program, as I mentioned, we've seen patients do really well on this. So patients that were overdosing before, no longer overdosing, people stopping using fentanyl from the unregulated supply. But we have no evidence to back this up just yet. So that's a bit of a limitation to the program right now, but it is being evaluated. So we don't know the effect of the fentanyl patch on overdose. In our clinical experience, it does seem to help. And just theoretically, it makes sense. You're maintaining your tolerance to full agonist opioids. That's going to help reduce your risk of respiratory depression when you're using other unregulated opioids. Another limitation to the fentanyl patch program is it does involve a lot of collaboration and a bit of capacity building to get it up and running. So Chrissy Sutherland started this in our own clinic, and we did it all in-house. And then there was a lot of capacity building that she did to work with other pharmacies so that we were able to expand the program. So if you're trying to bring this to your community, it may involve a bit of that. I know that in Ontario, you have a patch for patch program. So that's already sort of, you're part of the way there, but these extra nuances about the OUD indication and some extra little tidbits may be helpful to enhance that collaboration. Thank you for listening.
Thanks so much. So I want to invite all our panelists to come back online now. And if people have questions, then please put them in the chat and we will try to answer them. So Louisa and Sam, if you're there, you're welcome to come back and join us. Perfect. Well, I can start us off with a question. So just reflecting that really, our practice has changed so much. Like some of these things we couldn't even have imagined, 5 years ago, right? So I wonder, what does that mean for us, right? Like, how can we be expected as providers to make our practice so nimble? And do you think that 5 years from now we're going to be doing completely different things also?
Jay, can you shut off the fan?
I mean, I totally agree, Nikki. And I think, as a primary care physician, I think a lot about this just from like a what is, now that substance use in our field has become like an emerging area of expertise. It's like that kind of circle of, okay, sorry for the wind chimes in the background, it's my neighbor. But how we kind of start in the inner circle of like things that we could hopefully have as basic capacity that we would hope that everyone, like for my own specialty, I would hope that every general internist can manage withdrawal as an inpatient, and then call for help when they need it. And then like as people build capacity. So, I practice as a substance use physician in Vancouver. Like I am not super comfortable with fentanyl patches because I don't do them, because our clinic doesn't do them. And so I refer out to, PHS or other places for other kind of like higher level of care and management. So I think that is kind of the way that this will all go, is like we can hope that there's this base level of knowledge that we can continue to spread to those in our fields, and then thinking about like how do we build capacity to expand that level where everyone's comfortable, but then still I think there's always going to be a role for expertise like there is in every field.
I think, to follow those thoughts, Sam, I do agree. And I think in general, there's a continuum when it comes to the treatment of substance use. There's a continuum in people who use substances. I think some of the important things that have come to light in the last couple of years is what you said is really, as practitioners, we have to all really become comfortable with this in some shape or form. And even if we're not all practicing the same and have the same expertise, this is what I spend so much of my time just saying. We need to just even get comfortable in with ourselves, with asking the right questions, so that we can even identify people who use substances, so we can offer them the help we need. Because I feel like that even that basic step isn't happening sometimes in some areas, in primary care, in our emerge, all sorts of places. So I think just being comfortable with saying, do you use substances? What substances do you use? What does it look like for you do you want help with this? What does this look like for you? I think just those basic things is getting comfortable with that conversation, and then understanding the options, that it's not a cookie cutter approach. Is everybody's approach to their treatment has to be slightly different, as you said. Some people are doing the fentanyl, patch for patch program. Some people want to quit drugs completely. And I have many patients who do not want to use drugs anymore. That's drugs aren't an option in their life. So for those patients, what are you doing? What about patients who are just going away? I have many patients who need to stop using drugs for a very short period of time because they're going somewhere. I think we need to just be more comfortable with that in general.
Yeah, I mean, I think the working in an unregulated drug supply poses unique challenges. The drug supply has thrown down the gauntlet, and we as addiction medicine need to take that up, and we need to be flexible and innovative in how we adapt to that. And I think that's basically what all of these presentations in this panel show. And I think a common theme also is like relying on the pharmacology and the pharmacokinetics of the drugs in the drug supply, and also what we have at our disposal can lead to those innovative approaches. I think that's basically what we've all touched on today. And I think part of implementing that is challenging within ourselves, like our own inertia and rigidity, like, oh, well, like this is how it's sort of supposed to be, but we need to be creative, because the drug supply is, and we need to, be better as we work towards a regulated drug supply.
Thanks. So I'm still not seeing any other questions in the chat. So please be brave if you do have questions, because there's, I think, a lot to unpack here. But maybe another question I have, or a common thread, was there's not a lot of evidence for many of the approaches described yet, or minimal evidence. So how does that sit with you, having been steeped in like evidence-based medicine? Um, uh, yeah, how do you what do you think about what happens when if your client has a negative outcome, which will happen to all of us at some point? How do you sit with that?
I think this is one of my pet peeves. Medicine really makes evidence. It's not evidence makes medicine, right? And I think we might need to stop always worrying about evidence-based practice, which I think is so important. But in this crisis, we're in a crisis right now. This is crisis mode. We're all in crisis mode. What are we going to do to stop patients from dying, and for people to be safe and have a good quality of life? And we say, there's not a lot of evidence for this, but we're making the evidence right now. Everything that everybody talked about, this will be evidence, right? We just haven't gotten there yet because it's so new. So I think, things we do are scary. It makes me nervous about a lot of the things I do, but the option for many of my patients is that they die. So I always think that the treatment and the discussions I'm having with my patients about their treatment options are definitely less risky than them using a contaminated drug supply, and buying from somebody who they don't often know, or they have no idea what they're getting even in their supply. So I always keep that in the back of my mind, is that what I'm doing is still safer. And any way I can keep the people I treat safer is the most important, I think, aspect of all of this. But I am nervous very often about many of the treatment approaches that I approach, especially as Sam was saying, patients who come in. I also do a lot of work in the ICU for people who come in who have overdosed, or those who have had severe traumas and are using a lot of fentanyl, giving them 8 milligrams of dilaudid Q15 minutes IV just to help with their withdrawals. People are scared to do that. But when you put it in the context of the amount of fentanyl and the contaminated drug supply, they're in a controlled setting and it's safe. And I think we have to remember that.
Yeah, I think, like Louisa said, everything has to sort of start somewhere. I think if you have a strong rationale for why you're doing what you're doing, that makes sense, taking in mind the context, how the drugs work, all those sort of things. One thing that I observed at PHS is really like the program started small group of patients, and you observe, and then once you have sort of a proof of concept, then you can expand. So I think that can be a way forward in innovation, is using that approach. I also think this is a good call to action for people to engage in substance use research. There are addiction medicine research fellowships out there. Sam is part of one now through the BCCSU, and that this is what makes the evidence, and we need people to engage in that. And there are avenues to build those skills if people want to do that.
Thank you. Just a comment here that it's nice to see that not everyone has access to inpatient care. So nice to see what's happening in an outpatient setting, and yeah, that's important because it's true that even where you do have access to inpatient settings, it's not always supportive. You don't always have an addiction consult team. Okay, let me just see here. It would be nice to have a more streamlined system to help people along the journey, as well as we all know the treatment goes well beyond the initial and immediate treatment. We need better pre-maintenance and post-care resources. Any reflections there?
Yes.
Yeah.
I think we
Yeah, go
agree.
ahead. I think yeah, we all agree, and I think that the reality is like okay, so two of you are from practicing in the downtown east side, where I'd say there's like a higher baseline capacity, right, of OAT providers, and in parts of BC and parts of every province in our country to greater or less extent, there's not that even baseline comfort or knowledge about OAT, right? Even in Toronto recently, there's cases described of like academic centers where there's no like methadone or SROM on formulary, right? So the depending on where you are, really these approaches unfortunately are inaccessible. But I think that providing like publishing through Medify through the BCCSU these guidance documents will go a long way to helping providers feel connected. Um, Olivia, I did have a question for you about so how does the fentanyl patch program interface with the fentanyl powder sales program? Like, can people transition to one or the other, or what happens there?
So basically, they're separate streams. So it's easier to think of the fentanyl powder program like IOT, and the fentanyl patch like similar to like oral oats. So because it's a long acting option, it's different than our fentanyl powder. So they're all sort of under the same umbrella of safer, which are our fentanyl products at PHS. So people can be on fentanyl patch plus fentanyl powder. They wouldn't convert between one or the other. You actually cannot convert the dose between those two things. So it's fine for someone to be on the long acting. Similarly, if someone is on any other form of oral oat while on the fentanyl powder, that's also totally fine, or on no oral oat while on the fentanyl powder. So they're complementary, and basically we just have the fentanyl patch as part of our suite of like oat options is how you could kind of view it.
Um, Question here: do you have any thoughts on how to start increasing number of primary care OAT providers in more rural or suburban areas?
I was just thinking, like we are, yes, as much as the drug supply is changing and so much, like also medicine is changing. And I know there's a rural OAT program in northern BC that was started kind of like one physician or two in a local community and has spread virtually to a lot of different places. So I think that virtual care is one option that is probably underutilized and could be implemented a lot more, because again, like this is we at the volumes will differ everywhere, but like for, and obviously Vancouver is a different center, same with Toronto. Like there are numerous rapid access clinics in Toronto where all they do all day long is substance use treatment. So for someone, even if you have a primary care physician in a more rural community, like there's a lot of competing kind of interests in that, and the ability to actually manage an entire community with requirements for substance use treatment may or may not be feasible for one person. So having that like outsourced ability, but I say that as a very, very urban physician.
Yeah, kind of building on that. I mean, there is funding in BC where rural family doctors can come to urban centers, like they come to the rapid access clinic at St. Paul's to actually like do rotations and see. Usually it's for like a week or a little bit less than that, but that seems to really increase their confidence, because I think reading about it is different than actually doing it. So when you see a patient, you're like, well, is this too sedated to increase their methadone? I don't know. That is really helpful, I think, guidance. And it's nice that there's funding support. So it actually makes it accessible for people to do.
And I think like where I live in Timmins, I run rural coastal addiction call. That was my 15 calls today. So I get calls from communities that are fly-in communities only. And I do them over the phone. These people I've never even seen. They sit with a nurse at a nursing station in a northern community where there is zero physician access. And the nurse sits with them and they call me and we talk about it. And I start them on OAT at their community by just doing it over the phone. This is what we have to do. We have no other choice. I can't let people in these, many of them are rural Indigenous communities, die just because I don't want to talk to someone over the phone and I haven't seen them face to face to start them on a life-saving treatment. So we have a system where they go to the nursing station. The nursing station calls us. We have a discussion with the nurse and the patient on the phone. And the nursing station is now, this is new in the last few years, are now have Suboxone in stock, buprenorphine naloxone in stock at the nursing stations. They did it 5 years ago. So even that's a change, that now people can walk into a nursing station in a rural community and access Suboxone and phone us, and we treat them that way, because sometimes you can't even get OTN access, or even virtual access. Like I go to some communities, we show up and there's no internet sometimes, they don't have cable TV. So, but there are ways to do it. It's challenging, but I think ethically people deserve to be treated if they want help. If people are asking for help, we have to treat them.
Question here. Patients who are on specialized OAT programs, i.e. fentanyl patch, what happens when they're admitted to hospital for unrelated reasons? Are the hospitals continuing their patches?
Yeah, so this is a great question. In the Lower Mainland, we're lucky that basically every hospital has an addiction medicine consult team. So they do continue them. There's also been a lot of that capacity building that Chris Sutherland has done, and PHS has done, reaching out to the emergency departments in our area, letting them know this is what we're doing, this is what you might see. Because we did have a few patients that were going to the Emerge to like get the patches replaced, and it kind of threw off how we were able to track the patches. There was one hospital that didn't have the same addiction medicine expertise. And we had one patient that lived in that community. They kept taking his patches off. He went to Emerge like 3 times in 3 weeks, and the patches kept being removed. And we were like, stop doing it. So a little bit of outreach there like helped. I think if you don't have such a large program, maybe you have fewer patients and you're starting it out, you might want to give patients like a card that their providers can call you so that you can provide that education, because you definitely do not want the patches to be removed and not started and have your patient be in horrible withdrawal, because it's not a conventional form of OAT. So that may be a way that if you don't have enough patients to like send out sort of a letter to your local emergency departments, it may be a way that your patients can have continuity of care on the inpatient side.
Yeah, just thinking in our setting, like it's hard enough to get someone's like SROM or methadone continued often, or buprenorphine sometimes, or even like getting someone their scheduled extended release buprenorphine injection on time, like while they're admitted to hospital, or their IOAT or safer supply. Yeah, it's a huge challenge, making sure that continuity happens when clients are admitted.
And sometimes I think that's why sometimes a smaller community is easier. To be honest, there's some benefits to a small community because there's only a few of us to call. We know all the patients. I'll see my patient at the grocery store. I'll see my patient downtown. It's very different in a small community. So there are some benefits in that way that, if for example, if a patient of mine goes to the Emerge doc calls me and says, "Hey, Louisa, your patient's here." "Oh, okay, just do this." It's very easy because there's so few of us working in the area. So yeah, there's some benefit to that, I guess.
Okay. Well, last call for any questions in the chat now, and in the interim, I'll just invite our panelists to give any final reflections or anything else that we might not have asked about.
Thanks for having us. It was great. It was great to meet you all, and thanks everybody.
Okay, amazing. Thank you for everyone who's attended, and I will give you back 20 minutes of your afternoon.